let's start. So, yes, Assalamu alaikum. Welcome everyone on board. Today we will be discussing just a few basic concepts about uh, ICU. Okay. So, just let me. First question, Hassam, do you know what is difference between ICU and HDU?
Sir, ICU is intensive care unit and HDU is high dependency unit. Whenever a patient is requiring one organ support, we usually send this patient to high dependency unit. But this organ support should not be ventilatory support. Whenever a patient is on two organ support or the organ support is ventilatory support, so we do send him in ICU.
Okay, so actually there is some other terminology which I cannot recall at the moment. You should also know level 1 care, level 2 care, level 3 care, something like that. Okay, so there is another terminology which is written about it. So this is one point. Maybe you can just check it out, this thing. But the difference between HDU and ICU, as you stated, that one organ system other than ventilatory support is HDU. More than one organ system or ventilatory support, it's ICU. Okay. So like the questions which can be asked or which you should know as a concept, what will be the ICU admission uh, indications, if someone asks you, because actually this is a slightly atypical question, and actually this was asked to me in the exam and I was just smiling at them because I had no idea. I was not mentally prepared for this question. So Sam, what will be the possible indications for ICU admission?
Sir, as we discussed earlier, that if a patient is requiring ventilatory support,
Okay,
if a patient is
so
ventilatory support
mainly
can be divided in,
very
if a
broadly,
patient, sir,
very broadly you can as it is, as actually it is, whether it is medical reason or surgical reason. Okay, so
sir,
you can divide in two basic parts. So
sir,
first of all, because as anesthetist, what will be the surgical indications of ICU admission
sir, post-operatively, any major surgery in which we require vigilant monitoring
with reference to bleeding, with
with
reference to
reference to hemodynamics, bleeding,
hemodynamics? Okay,
laboratory parameters,
and
temperature control.
problems related to homeostatic system. Homeostatic, not hemostatic. This is hemostatic. These words look similar. What will include in homeostatic things, Hassam?
Sir, homeostasis is basically maintenance of equilibrium, normal equilibrium of the body,
Good.
normovolemia, normal electrolytes, normothermia,
Okay,
normal
so like electrolytes,
glucose.
acid base, okay, volume status. So all good care is actually homeostatic conditions. So usually, or if any surgery in which the patient needs to be electively ventilated. Okay, so like
Sir,
elective ventilation will be one of the uh, surgical, purely surgical reason. Okay, so you can add on, just think, and maybe you after some time you will find some more indications. Maybe we are not able to find at the moment, or I cannot recall. So this question, because we are having a conceptual discussion. Okay? So anything missed, please note down, and you can find more detailed answer. Okay, so just note down, because this question is usually not discussed. So it's a what are the indications to for ICU admission? So this question should be what? Okay, what about medical indication? Some of them will be
sir,
like that. So medically,
any
which
decompensation of the main organ system.
very good. So it will be either commonly lungs or heart or liver or kidneys, okay,
or lung.
or brain mainly. Okay. So now you can think that what will be the decompensation with lungs. First of all, first of all, how will you evaluate? Like for example, because now I am expanding my discussion. So just tell me one thing, how can you evaluate the respiratory system with reference to any decompensation? How will you evaluate?
Sir, it can be divided into whether
I'm
there is
sorry,
an issue in the
Hassam,
parenchyma.
just
Sir,
a second, because this question was asked to me in ICU table viva. How will you assess the cardiovascular system? Can you believe this? And they start. I had not read it. I had not
sir,
read it, and luckily because my concept was clean and I was able to answer them because they started from the same way which you are telling, like in the clinical way, and then investigations and bedside, like you can say monitoring as well as investigations, point of care testings, what you can do to evaluate whether the patient will be decompensated or compensated, whether the patient is stable without any support or whether the patient is stable with some support. Got my point? So
sir.
I will just give you a practice, and later you can we can just have a quick words about it. So quickly, as you were telling, respiratory system, how will you evaluate?
Sir, we will evaluate whether there is a problem in parenchymal functions or whether there is a problem in the respiratory tract
Okay. So respiratory tract, you can divide it in upper and lower.
and lower. Sir. Yes,
Okay. So how will you evaluate?
sir. Sir, evaluation
What's the first
starts
thing?
from history, examination, and investigations.
Okay. Okay. So history,
So
there
if
will
we
be
skip
some things.
history, sir,
History.
sir,
There will be some points related to history, some points related to examination, some points related to like investigations and then monitoring. Okay. But
sir,
but honestly speaking, practically, what you do if you want to immediately quickly raise reference to ICU, how will you evaluate
sir,
quickly?
examination. If we start with examination, we will
Okay.
look at the respiratory rate,
Very good.
respiratory
Pat,
pattern,
very good.
whether the patient is having central or peripheral cyanosis, whether he is
Sinuses.
using accessory muscles or not, whether he is
Okay.
on some sort of non-invasive or invasive ventilation, and the parameters
Distress.
related to it.
Yes. So, then you can, the parameters will be like FiO2 versus
Sir, level of yes, sir.
PaO2 and SaO2. Okay. So, FiO2
Yeah,
and PA,
yeah,
because
onset is also important.
I'm sorry.
Onset is also important, whether this is sudden onset or it is gradually
Very good.
increasing.
Of course. Of course. Okay. Actually, this is a very open-ended question, by the way. Okay. And I don't know whether in which way they will take, but because we are right now we are just doing a practice. So you should know how to gather your answer. So like history of anything which is related to respiratory system, whether any chest infection, upper, any signs of upper or lower, upper or lower respiratory tract infections like sore throat, even that is a respiratory system, and then you go further down and cough and sputum and fever and respiratory distress, and you will evaluate as he's mentioning respiratory rate, respiratory pattern, cyanosis, distress, and then how you are managing it. Like if you are assessing a patient with the respiratory problem, the basic thing which you will be assessing is through how much FiO2 you are giving and how much PaO2. Is it important what you say it?
PF ratio or Berlin criteria.
PF ratio, okay. So because how it is related, because this now you can open up the discussion to the diseases as well. So ARDS, we label it as mild, moderate, or severe ARDS on the basis of PF ratio. Okay. Similarly, whether the patient is oxygen dependent or not. Okay. If the patient is oxygen dependent, which way it is going, whether it is nasal cannula or face mask or with face mask, with the reservoir, okay, or with the BiPAP, CPAP, okay, and then ventilator, okay. So if they are asking you with reference to ICU, so you can say on the basis of history, examination, and investigation, because I'm telling focus with reference to ICU. So with reference to ICU, when you are assessing the patient, so this may be the scheme you can follow. So the patient will be another category, but you can say the patient may be weaning. So weaning patient, just extubated. So these things will be, because whenever even these words are important for the practical knowledge as well. And when you are dealing any patient in ICU, actually this is the pattern you follow. Okay. So one few more things, that what point of care testings or what point of care things you can do to check the status, respiratory status.
ABG.
Sir, ABGs,
Very good. What else?
sir, lung ultrasound.
ABG is very good. Now this is where time of focus, lungs, point of care ultrasound of lungs. Okay. Then what else? Traditional chest X-ray.
Sir, chest X-ray,
What
portable
else?
chest.
PEFR.
Sir,
Okay. What else?
Auscultation.
Auscultation. Okay. The clinical examination will be, of course, inspection, uh, percussion, palpation, or these are things are of course there. Anything else? You are missing something very simple. Pulse oximeter. Sometimes we can miss very simple thing. Whenever we are assessing a patient, first thing we put is pulse oximeter. Okay. So in our anesthesia machines, ICU setup, we don't usually monitor end tidal, but I think in modern ICU ventilators or monitors, I think end tidal CO2 they are also monitoring. Yes, yes, Dr. Hassan. Yes, Hassan bhai. You raise the hand. Okay. Okay, Hassan. Agreed.
sir,
Okay. What else? What are important things? Maybe now we can broaden with reference to ventilator. Whenever we are assessing a patient on ventilator, what things we can what things you usually how we explain
sir, mode of ventilator,
mode.
patient's compliance to the ventilator,
Very
which is
good.
shown by peak pressure, compliance
Pressures
of
like
lungs,
peak pressure, and because where
plateau
usually
pressures.
in anesthesia mainly it is peak pressure, but in ICU usually it's plateau pressure. Okay, which are more important. Of course, peak pressure is there, but plateau pressure with reference to lung compliance, static compliance, this is more so here. So pressures, then what else?
Amount of PEEP and
PEEP.
FiO2 we are giving to the patient.
Very good. Like PEEP, and then of course, what sort of another thing with reference to mode, that it is purely ventilator based ventilation, or patient is also
Or
participating.
synchronized.
Okay, like it is synchronized versus unsynchronized, or patient is wholly dependent on ventilator, or patient ventilator is helping, because there are so many modes. ACVC is another mode. There are advanced modes, newer modes which are not commonly used. I'm not sure whether now it's available in Pakistan. PRVC, pressure regulated volume control. Okay, so in this is a smart mode, and actually in that whatever volume you have set, the ventilator will be wise, and like for example, if you have set 500 ml, the first breath will not be 500, first breath may be 300, and then the ventilator will assess the pressure. So if it is not creating too high pressure, the next breath may be 350, and then 400, and maybe over 4 or 5 breaths it will achieve 500, within the limit pressure. So it is called as pressure regulated volume control. There are different mode name in different ventilator models, but the basic concept is that the ventilator is smart, and it is taking care of pressure with reference to volume. Okay, so whether when you are assessing a patient with reference to ventilator, respiratory rate, tidal volume, pressures, PEEP, because PEEP is a very important factor. Okay, if patient is on high PEEP, it means patient is not in stable condition. If patient is requiring high FiO2, it means patient is not stable. Okay, similarly, if patient is totally dependent on ventilator, patient is not stable. So these are the parameters, because same things are there whenever they are asking you about even ARDS or VAP. If they want to ask anything about the well-being of the patient, these are the basic things. Okay, so maybe I've missed ECG even. There are certain things which you can, like if patient is tachycardic and there is a high FiO2 requirement, or patient is hypoxic. So this is like you will find some, even there may be some arrhythmias which will be triggered because of that decompensated respiratory system. Okay. So this is how you can correlate your findings. Okay. So this is how now, I've given you one example. So similarly, you can evaluate the CVS, you can evaluate the liver, the kidneys, the brain. So quickly, I will in few minutes, I will quickly explain, and then like you can understand what I'm trying. Like same approach will be with reference to cardiovascular system, like any finding in physical examination, tachycardia, any arrhythmia, like high blood pressure or low blood pressure, vasopressors, inotropes, antiarrhythmics, like like with reference to peripheral circulation, because as this question was asked to me, that how will you assess the cardiovascular system? So the conscious level will be telling you the basic physical examination. Patient is sweaty, patient is cold, clammy, that these things will be telling you. And of course there will be some history, there will be some background clinical information, but further on, from there on, ECG, X-ray, now again the POCUS will come into, so POCUS will be there, cardiac output monitoring will be there. Okay, this one, uh, quick focused echo will be one of the thing, that how good is the cardiac contractility, how good are the chambers, how good is the, like a patient needs. For example, if a patient with cardiovascular instability and vena cava compressibility will tell the whether the patient needs fluid or not. Contractility good or bad. If contractility is not good, you will be adding inotrope. Okay, if we have cardiac output monitoring, you will get to know how good is the systemic vascular resistance. So if systemic vascular resistance is low, you will be giving vasopressor. Thereon, like the assessment will be like this. Okay, so you will be using the parameters, and again ABGs will also come into account. Like for example, if the patient has some arrhythmias, so first thing you do is to see the blood gases, whether any electrolyte imbalance triggering that arrhythmia. Okay, so like similarly, chest X-ray, you will find some findings with reference to cardiac system. So that's how, because this is a question they can ask you. Because I have give you enough hint. Same theory will be for kidneys and neurological system and liver with reference to the any history, and you will see, yeah, like for example, kidney, you will do urine output or any swelling or any urea creatinine, electrolytes. So that's how they can ask you this question. So if you have understood what I wanted to give you, because it is a quick review, so maybe I will pass on to next. Uh, so up till now, if I just revise, we discussed that what will be the possible indications, what will be the possible reasons to be admitted in the ICU, and how you assess the patient in ICU. There are with reference to the stomach, there are some journal things which are there for any ICU patient assessment. So Assam or Ibrahim, anyone raise the hand and tell me what are the journal things which you assess in any ICU patient other than systemic. So we have just peeped into that part. So now you can understand any ICU patient, you check the respiratory system, cardiovascular system, renal system, neurological system. What else other than that? What are
Sir,
the
what kind of feed the patient is taking? And is it
so you can say that input, intake, output. Okay. So intake, output, and in that there will be fluid balance and there will be nutrition.
caloric requirement?
Nutrition. Okay. So this is what you are
Will
telling.
also
So
for
nutrition,
anesthesia.
Ibrahim, the next part I will ask you. Okay. The one, or
Sir,
you,
we
if you
have,
want,
Sir Zishan, we have
yes,
other exam candidates as well. Dr.
whosoever wants
Zishan
to.
is here, Dr. Osama is here. You can
Okay, I
also
will
involve
ask.
them.
I want to because I want everyone to participate. Okay. So just a second. Please continue. Ibrahim, you want to speak out? Please speak out. Then Hassam.
Yes, sir. In general management, we first of all ruled look for feeding, and then we will also look for analgesia, sedation, thromboprophylaxis.
Okay, just a second. Just a second. If you are only thinking about this mnemonic, please, this will be overacting. Okay. I know that all of you are interested in mnemonics and everything. Try to be logical. Okay. You are right. Your answer is not wrong. But you are telling feeding, ulcer prophylaxis. What was N? Yes, Ibrahim. What are the other components?
Sir, other are the hypothermia, thromboprophylaxis,
Okay.
and glucose.
Is this formula or I think it is sorry, I'm using the wrong formula. Fast hug. Fast hug, am I
Yes, sir.
right? Fast hug. So feeding, analgesia, sedation, thromboprophylaxis. What is this H? This is glycemic control. This is what is U?
Ulcer prophylaxis,
Huh? And what is H?
hypothermia treatment.
Hypo.
Yes.
Okay. Anyway, just I know that because you see we forget. So this is fine, but try to be logical. There are something which are not written here, and they are also very important. What about lines? Is lines important?
Yes, sir.
Okay. What about positioning?
That's also mandatory.
Well, positioning is very important. Okay. Why? Because this is also related to bed sores. Okay. And bed sores can become infected, and it is a bed sores or lines, and these things are very important because this will increase the mortality morbidity. Okay. So these things. Whenever we are talking about intake output, so it is not only fluid balance, urine output, okay, and as you mentioned about nutrition, that how much caloric requirement and how much patient is taking, and what is the another end point for nutrition? One is intake output. What else? There is important point which should know.
Basal metabolic rate.
No. That is requirement. Nitrogen balance. Okay. Like it's like fluid balance, you can say. That the patient should be in positive nitrogen balance, not negative, because it is like a catabolic state. So you need to increase the caloric requirement according to that thing. Okay. So what else? Anything else in this formula? Is there any part of delirium assessment? Is ICU patient prone to have delirium?
Yes, sir.
What about this neuromuscular blockers? What are the problems related to neuromuscular blockers in ICU?
Prolonged use may leads to neuropathy and myopathy.
Very good.
Myopathy.
What is the name of that disease, that condition? Critical illness, polyneuropathy, myopathy. Okay. So, but remember one thing, whenever you have to rule out other causes of weakness. Okay. So, so you can make a list that patient which medications. Okay. Medications. What are the common medications in ICU? So we talked about sedation, delirium, this fast hug formula we discussed. So usually, what are common medications in ICU?
Sir, antibiotics, sir.
Antibiotics. What else?
Sedatives like
Analgesics.
midazolam, propofol
Sedation.
infusion,
Sedation medication. So sedation, what are common things for sedation?
benzodiazepines, midazolam,
Benzodiazepine is
propofol
midazolam.
infusion,
Propofol. What else?
fentanyl, opioids,
Fentanyl and other opioids. You are missing one important thing which is used for weaning as well.
And, alpha 2 agonist, dexmedetomidine, sir.
Presidex. Okay. This dexmedetomidine. So antibiotics, I know there are so many details of antibiotics, but usually you should know what are common gram positive, gram negative, anaerobes, okay, and MRSA, and patient with the penicillin sensitivity, okay. So you should have an
and
idea, rough idea.
antifungals.
Very good. Antifungals, antimicrobials, antivirals. Okay. So this is one. So antimicrobial treatment is one of them. Sedation is one of them. What else? What other medications are used commonly? Please, one person. Who is speaking right now? Just continue, please. What about nebulizations? Okay. So nebulizations with salbutamol or steroid
Duolin, Budicort,
or ipratropium. Okay. This is one thing. Then, if you just continue to for respiratory system, there is one thing which is N-acetylcysteine. What is N-acetylcysteine? Zishan, where is Dr. Zishan? Where you mentioned about Zishan?
antagonist of paracetamol toxicity,
Sorry?
antagonist for the paracetamol toxicity.
Okay, are we talking about paracetamol poisoning? We are talking about
Sorry,
general care. So most probably, I'm not asking about paracetamol poisoning.
mucolitis.
N-acetylcysteine is a dietary supplement, and it is usually used as antioxidant properties, and it is also used to
Mucolitis.
treat acetaminophen overdose, and it is used as a mucolytic agent.
Yeah, this is the last thing which you have spoken is the incoming in the general care. It's like a mucolytic. So the sputum will be thinned out and will be easily either suctioned out, or with the positional drainage it can be removed. Okay. So N-acetylcysteine is another thing. But what about steroids? Okay. And what else? What about ulcer prophylaxis? Which medications are being used? Because
Proton
there
PPI.
is
Proton
a debate between ranitidine versus omeprazole. I don't know which is the current guideline, which is good or which is bad. You should know about it, because they every other day they change the recommendation. So you should be knowing which is better, ranitidine or omeprazole, and in the trials, with reference to trials. Steroids, and they are using it in, if patient is not responding to vasopressors and inotropes, and so all the things, fluid management, after that steroids come. There may be some other indication for steroids as well in like recovering phase of ARDS. Steroids are being used. What else? Zisha, Hassam or anyone wants to add on, please?
Thromboprophylaxis.
Very good. Thromboprophylaxis. Okay.
And antiemetics.
Antiemetics. Okay. Few words about thromboprophylaxis in ICU. How thromboprophylaxis is being given?
So either they can be given as in a prophylactic dose, or they can given in the therapeutic dose, depending upon the condition and the risk
Then
of developing.
just a second. Just a second. Who's speaking?
Zishan.
Okay. So first of all, Zishan, if we are giving in therapeutic dose, will it be called as thromboprophylaxis?
No, so that will not be prophylaxis.
Okay, so please try to be very specific. They are making you a
Yes.
consultant, so you should not speak without comma full stop. Think before speaking out. So if someone is asking about thromboprophylaxis in ICU, should your answer start from medications, or you can tell something else?
So we can start from the general maneuvers, patient mobility,
Mobility, ICU, in
like
ICU patient will least likely
limb.
be to be mobilized.
Sir, we can like limb movements, limb lower limb movements, calf compressions, like
This is
calf compression
okay.
exercises.
Oh, okay. Just a second. First of all, think about dress. Is there any specific dress which is as thromboprophylactic?
So they give tight stockings
There is a specific name for it. Elastic stockings.
and elastic stocking.
Okay. There may be some other name as well. Please reconfirm about it. Okay. Then, as you were saying, compression devices, limb compression devices. Okay. Then what you were saying, pressure, it also physiotherapy. There is a role of physiotherapy. This is not only with reference of pulmonary toilet, okay, it's also for thromboprophylaxis. Because pulmonary toilet means we use this mucolator sachet, and then we do this like chest physiotherapy to do the removal. Okay, so and also it's like a for thromboprophylaxis as well. What else? What about fluid management? It's fluid management important for thromboprophylaxis?
Yes, sir. We should keep the patient enough hydrated to keep the viscosity, a normal viscosity of the
Yes.
patient.
Okay. And is like weaning trials and early extubation, or like you can say, like try to minimize this ventilatory support, that will also related to thromboprophylaxis. Okay. As you were saying, ablution. So of course, in the patient cannot move well in ICU. Even if in some conditions, if patient is awake, patient can sit on the chair. So that is also part of thromboprophylaxis with reference to mobilization. Okay. So this is some, because this and by the way, because up till now we have not discussed any specific topic, but now I'm trying to touch. So actually these things are there in the management of sepsis. These are all things which are all good, and good ICU care is part of sepsis bundle, because definitions you can read in any book. There will be latest SIRS score, or Q SOFA or SOFA, or there are so many ICU scoring system. They can ask you that how to assess the severity, like how to assess the prognosis of a patient in ICU. Okay, so in that way they are actually asking you the scoring systems. So there will be actually some scores which you are doing as a journal, and there are certain specific scores. So specific scores are related to specific conditions or specific disease, like for example Renson score or this Glasgow score. These are specific for example, pancreatitis. If you are assessing delirium, so there are score like this CAM ICU or Richmond agitation sedation scale. These are for delirium. If you are talking about sedation, so sedation, this is Ramsey scale. Okay. Then if you are talking about sepsis, so QSOFA is one of them, SIRS is one of them. Similarly, you will find so many scales, and you can touch every. There will be some diagnostic scales, some diagnostic criteria with reference to, for example, VAP. So they are all included, and you should know. You should know them. Okay. These Apache or this SOFA. There are some more scores as well. So you should be knowing about them. Am I right? So, okay. So in we will go in some details of certain topic, but I'm just trying to focus what I was trying to tell you in this discussion. So actually, what else? Let's finish the medications. Any other medications which are commonly used? Just think. It's been a while since I worked in ICU, 10 years, because I am out of ICU. I'm not working in ICU anymore. Oh, this is sort of weak topic for me, actually. Yes, anyone, please? Anyone wants to add? So we will go to our next step. Assam, do you like to add on, please?
The inotropes and vasopressor.
Yes, few words about inotropes and vasopressors. Actually, this is sometimes we are not understanding fully these inotropes and vasopressors. So, like if we are talking about vasopressors, so first line is norepinephrine, okay, and it is also first line in sepsis, okay, and then of course epinephrine is both actually dual, both as vasopressor and as inotrope, and the last one is vasopressin, okay, and the inotrope like the butamine, okay, and milrinone is being used. But remember one thing. So what is the baby of norepinephrine, which has a weaker effect but almost similar effect, not 100% similar effect? What medication you can say?
Phenylephrine, sir.
Phenylephrine. Phenylephrine is baby of norepinephrine. What's the basic difference between phenylephrine and norepinephrine? Or in addition to the potency?
Sir, phenylephrine causes reflex bradycardia.
Very good. It does not have beta effects. So norepinephrine have some beta effects. So it does not cause bradycardia. Okay. So this is the basic difference. And another point about norepinephrine. Norepinephrine ideally should be given through central CVP or PIC line. Okay. So this is one thing. And usually we are giving with the syringe pump, of course. What's the problem with the butamine?
Sir, it is also a beta 1 and beta 2 agonist, so it can cause skeletal muscle beta 2 vasodilation.
So
it can also.
What will be the effect on SVR?
It will SVR will decrease, sir.
SVR will be decreased, and actually it can cause hypotension, by the way, because of low SVR. The patient can have vasodilatation, and so usually whenever they are giving dobutamine, they are giving some epi, small dose of epi. Milrinone is also. What is milrinone?
Milrinone is a phosphodiesterase inhibitor, sir.
Okay.
It is pertinent, and it is given. It increases the contractility of the heart, basically, and most commonly right heart. So it is usually given in the right heart failure in some practices.
Very good. Yes, very good.
So it's not
vasodilator, and it is used in right heart failure. So it increases the right heart contractility. So the like norepinephrine. What about epinephrine? Epinephrine in low dose, it has more of beta effects, and in high dose, it causes more of vasoconstriction. And vasopressin is a very strong, it's like ADH, the same analog. So actually, it will have more potent effect. So with reference to vasopressors, whenever we are using vasopressors, remember one thing, that patient can have gangrene in the limbs. High dose of vasopressin will cause gangrene. And tell me one thing. Now I'm just asking you some guesses. Just tell me one thing. What are the consequences of high dose of vasopressin? What I have told you. Anything else you can tell? So that's why it's very important whenever you are using vasopressors, you should be thinking about on this ground. One of I have told you. Can anyone tell some more?
Water retention.
Vasopressors. Water retention, how?
Sir, ischemia to the
Gangrene, I have
distal
told.
peripheries.
Gangrene, limbs gangrene. So this is one of them I have told. What other ischemia is very dangerous?
Gut ischemia, sir.
Very good. So that's mesenteric ischemia. Okay. The mesenteric ischemia is very, very lethal. And that's why lactate levels are very important. Okay. So because every other day, very good, bowel ischemia. So that's very important. So whenever patient is on high dose of vasopressors, so limbs are very important, and mesenteric ischemia. It can occur in any other places, but these two you should be knowing. And then it should be given ideally through the peripheral system. So similarly, whenever they are using inotropes, especially like dobutamine, it causes tachycardia. So tachycardia is not a very good thing for the heart. So that's it. That's another thing you should be considering. Whenever patient is taking high dose of vasopressors, another important thing is uh, uh, like visceral blood supply is decreased. So actually, renal blood flow can also hamper. Am I right? So of course, when mean arterial pressure will increase, it will have a positive effect. Like you have to outweigh risk versus benefit in all these scenarios. That's why it's very important whenever you are using inotrope and vasopressor, you have to identify whether the patient you are missing something. If you are not taking care of fluid balance, actually you are just hitting without sense. So fluid management is very important. That's why whenever you are using vasopressors or inotropes, you should be thinking about fluid balance. If fluid is not there and you are just hitting the heart by inotrope, it does not make sense. So and another thing, that majority of our patients are fluid depleted. Even what do you think, the patient with low cardiac output or patient with renal failure, early stages, not end stage renal disease, patient does not need fluid. Even if the patient is on dialysis, patient still we need some fluid. Okay. So fluid balance is very, very important. So these are few words, basic concepts which they can ask you somewhere in your discussion with reference to ICU. Okay. So I was just some other points were just touching my mind and going. Anyway, I will just change the taste for a while, and I will just tell you what topics you should be knowing. For example, one of the topic is ARDS. One of the topic is sepsis. Okay. One of the topic is ventilator associated pneumonia. So actually, these are interrelated, and then of course multi-organ failure. So remember one thing: whenever anything which is leading to ARDS will need intubation, and then intubation will go to VAP, and then VAP can go to sepsis. Okay. And then sepsis can go to multi-organ failure. Similarly, maybe patient has sepsis and patient is septic shock, and you intubate, and then VAP can occur, and then after VAP ARDS can occur. So these are actually interrelated things. So whenever they are asking the topic, like I remember in European diploma in anesthesia and ICU exam, they asked one question. In that one question, actually they asked all major points about ICU. They touched about ARDS, sepsis, VAP. So actually everything was there. So you should don't read the topics in isolation. Try to correlate, because ARDS basic ICU management is the same, which we have discussed actually. That's why whenever I discuss about ICU, I start my discussion from these things, because general ICU supportive maneuvers measures you should know, because when in the table viva, whether it is even MCPS table viva or FCPS table viva, they start from ICU usually. So first table viva, so ICU you should know in a very nice way. And unfortunately, if you are reading separately, maybe you will miss. Okay. So individually, I will just try to, but first of all, I'm just trying to focus what you should know. So these are interrelated topics. In ARDS, you should know what is the diagnostic criteria of ARDS. Okay. What is the triggering factor of ARDS? What is lung protective strategies? What are novel strategies like this nitric oxide, ECMO, uh, uh, intermittent proning? One question I will ask with reference to ARDS, if you can answer, Hassam or anyone. What is the role of prone positioning?
Sir, in
Sir,
prone positioning,
Sir Zishan, please carry on.
Zishan, continue, please.
sir, in prone positioning, they basically by changing the position of the patient, so the portion of the lung which are less ventilated, so we target those areas of the lung which are less ventilated by changing the position by proning the patient, sir.
Actually, it is just like
Prone position basically decrease the alveolar hyperinflation, reduce cardiac compression of the underlying lung, and improve drainage of the secretion. And in the recent, there is a trial called ARDS patient trial, in which they said that the patient mortality benefit from ventilating the prone position used for greater than 12 hours. Okay,
very
for
good.
severe ARDS patient only. Okay. So this is the basic concept behind the prone position ventilation in ARDS.
Okay. Okay. So this is one question they can ask. The diagnostic criteria, all of you know, acute in onset, and then you know this PF ratio, and then this Berlin criteria. I'm trying to quicken up the thing, because it's very difficult to discuss in one sitting. So role of this prone positioning, you should know. This is one thing. And lung protective strategies. In lung protective strategies, a few words about it. That what, like one of them, for example, one is tidal volume, one is PEEP, okay, one is plateau pressure, and then permissive hypercapnia. Okay. So actually you coordinate these 3-4 things together. First of all, you start with low tidal volume, limiting the plateau pressures, and then you add PEEP, and then you set a goal of SpO2. Okay. So like that's how you do this lung protective strategies. Am I right? And you allow pervasive hypercapnia. If you're not achieving something, you will go to other step. Am I right? If can someone quickly elaborate more? Ikra?
Dr. Zishan, basically ARDS is a very important topic for ICU candidate, especially for the FCPS candidate. Why I start with ARDS sometime, okay? So they know the proper definition of ARDS. Okay, then the diagnostic criteria, as you already mentioned in Berlin criteria. So definition is very important. So ARDS is acute diffuse inflammatory lung injury leading to increased pulmonary vascular permeability, increased lung weight, loss of aerated lung tissue with hypoxemia, and bilateral radiographic opacities associated with increased venous admixture, increased physiological dead space, and decreased lung compliance. So this definition learned by heart, okay? It is very important. If you give the proper definition to examiner, they will give not even give you a good marks, but he will make an impression that you know about the topic. So ARDS is very, very important for FCPS candidate, especially.
Yes. Actually, yeah, yes, absolutely, you're spot on. But because as I told you that if you have the concept, because not everyone will be able to reproduce in the same word, but still they will pass. Because
नहीं
if
नहीं
they
डॉक्टर
you
निशान देखें देखें मेरी बात सुने जुल्करनैन बात कर रहा हूँ ये जो
yeah,
डेफिनेशंस है ना सर चंद ये बिल्कुल रोजाना ये लोग याद करें इसको लिख के याद करें ये देखें एआरडीएस की डेफिनेशन नहीं आएगी तो ये एक मतलब अच्छा इंप्रेशन नहीं है ठीक है ना
okay,
तो ये
okay,
तो
no
याद
problem.
करनी है
No problem. Actually, there are some
हम्म,
people who are not understanding Urdu. So we will
ओके
continue our discussion in English. You are absolutely right, but actually, again, I tell you something. We can only do what is in our hands. Okay. So if you know the concept, still my word is with the same. You are absolutely right. I'm not saying that they should not cram, but if some people they are weak in it, still if you have the concept you can speak out like the definition which you have told is the Berlin definition, and it's there in the articles written like that. So you understand the concept and try to reproduce in the same way with the same words it's as it is written. Okay. And okay, so these are few words about ARDS. What about sepsis? Some of the things I have already mentioned, but you should be knowing the sepsis bundles. So, what are VAP bundles? What are ventilator bundles? So, you should be knowing about it. And also, they ask about various this definitions, like what is septic shock, what is severe sepsis. So, you know about it, as you have practiced it, Hassam.
Yes, sir.
Recently, they added this SIRS score, which was not there before. In 2021, I think they added. Anything else added after that, Zulkarnain?
no
Q
you are
sofa
right
score,
sir
sir.
yeah Q sofa and Apache they are asking sir Muse and Muse there is one MEWS and there is one MEOWS. They are asking this question asked me in my Viva. So they are
Maternal
asking
earning,
scoring system. Yes,
maternal
maternal
early
early
warning scores.
warning score.
Yes.
And they are asking about at least everyone who is preparing for Viva, they know about Apache 2 and SOFA scoring with their,
Apache,
variables. They
Apache
are
2
asking
and
SOFA,
SOFA.
Q SOFA
Sequential.
also they are asking.
Yes.
Sequential
Actually,
organ failure assessment
yes,
system.
Hassam, what is basic difference between Q SOFA and SOFA?
Sir, Q sofa basically is a quick score which can be done at bedside, which does not need any labs. It
Very good. So this
includes
is the answer.
tachypnea,
This is the
altered
answer. Okay.
sensorium, sir.
Yes, yes. Like this is the basic difference that it does not need any lab investigations, because in SOFA you have to do some lab investigations. So it delays the start of antibiotics. So because the basic concept of sepsis management is that as soon as you have any a thing which is going towards the line of sepsis, you will take the culture, you will start the empirical antibiotic, you will start the fluid management, you will take the ABGs to do lactate, and then according to the situation you will give a fluid trial, and then you will add on another trial, and then you will add vasopressor, and then next step you add inotrope, and then next you will add steroids, and then you will give the empirical antibiotic, wait for the cultures. Okay. And then you will have a good glycemic control, and then you will be looking at the kidney functions with the creatinine, you will maintain a urine output, you will maintain the this hemoglobin. Okay. So this is the basic concept of sepsis. And then the supportive treatment, which we have a lot of things we have already discussed, that you should have a good feeding, ulcer prophylaxis, like positioning, chest physiotherapy, judicious fluid management. So actually, whatever question they are asking you, actually these are the common things which you will be there in majority of the answers. Okay. Similarly, what about if they are asking you about VAP, a number of things are the same. They will ask you what are the bugs for early onset, which I cannot remember right now. So you should be knowing what are the bugs for early onset, what are the bugs for late onset, okay? And what are different there, if I'm not wrong, there is Johan's criteria, and there are some other criteria. Otherwise, you should be knowing at least one of them, at least, okay? They can ask you another criteria, they don't fail. I know that this question comes like a bouncer, but if you know the concept, you will pass. Don't worry, okay? So most important thing is to have a good concept about the things. Similarly, because VAP and sepsis will be coming together. If you don't treat VAP, it will go to sepsis, it will go to ARDS. So these are the things which are interrelated. So in that there is some positional strategies, some medications, silver coated tube, and selective gastrointestinal decontamination. I'm just recalling my previous knowledge, whatever I had. So, but they will ask you the question like that, okay? And then I remember they asked me when I appeared in this EDA Viva. So, with reference to VAP, they were asking how to diagnose. So, I don't remember if anyone recall. You can tell what are the ways to diagnose the VAP. How to diagnose VAP with reference to bronchoscopic findings. How they do take the. Do you remember, Hassam?
Sir, I think so. There is a score, CPIS, Clinical Pulmonary Infection Score. If score
Okay.
is greater than 6, then it is likely a VAP.
No, actually, you're right. This is another question. I'm talking about, if you remember, there is colonies, like how sensitivity of sputum. There is one sputum. There is one protected specimen brush, something like that. And then there is this bronchoalveolar lavage. According to that, they will ask you about the how much colonies, because protective specimen brushing will be the most sensitive. Am I right? So even smaller number of colonies will give the diagnosis, or uh, uh, you will pick the bug. Okay. Similarly, sputum will be less sensitive. Bronchoalveolar will be number 2. So this is, I think, written in articles. So you should be knowing about it. Am I right? It's written in, I think, a lot of books. It's written. I don't remember exactly, but you should be knowing about it. Okay. Assam, if you don't know, if you are not read, please do read it.
Right, sir.
Okay. So, okay. So anyway, few more topics which they can ask you about ICU. One of them is delirium. Okay. So for delirium, they will ask you this. I remember the mnemonic was FIDA, fluctuating. I don't remember exactly. Fluctuating inattentiveness, disorganized. What is that? DNA. What will be the definition of delirium?
Fluctuating pattern, inability to concentrate, disorientation, and altered sensorium.
Altered sensorium. So this is FIDA. So this will be one thing. Then there will be type of delirium, whether it is hyperactive or hypoactive. Okay. And then what are the triggers, or what are the precipitating factor for delirium? Should be knowing that whatever factors we should be knowing, like there are some homeostatic conditions which can lead to like hypothermia, hypovolemia, electrolyte imbalance, hypovolemia, these things are factors for delirium. Okay, then like if some patient is dependent on glasses or visual hearing aid, if you don't provide them, this is a risk factor for delirium. Like it's very funny thing that if you put a lot of ointment in the eyes and then when the patient wake up, the patient can have delirium, because actually delirium topic is usually whenever we are talking about delirium, we are thinking about ICU. But delirium actually, there are two different, one is ICU delirium and one is post-operative delirium. Okay. So post-operative delirium and another topic which they can ask you, all of the points, majority of them are the same. Post-operative cognitive dysfunction. So you should have some words. I don't have a very good concept. What is extra in post-operative cognitive dysfunction other than delirium? I just recall, I can recall this topic, but I'm not sure what you need to know about it. Similarly, if they are asking you about the treatment, so treatment actually not, there is no specific treatment of delirium. All the factors which are precipitating, you will treat them actually. Correctable things you will correct. And then what are specific medication for delirium? One of them is haloperidol. Okay. Otherwise, you can have some midazolam. By the way, midazolam is also a risk factor for delirium. Can someone explain how midazolam can cause delirium? Especially with reference to post-op period. Can
Sir, by causing drowsiness?
no, drowsiness is not delirium. Actually, midazolam is not a long-acting. Okay, this is with reference to post-op. So if you have given midazolam, actually its effect if suddenly finish, the patient can be more aggressive. Okay, so this is related to that, and you will be surprised to know that low dose ketamine actually prevents. You can read about it. Low dose ketamine actually prevents delirium. Okay, or you can say good analgesia, because it's a powerful analgesic. So if you are using ketamine low dose in, it is actually sort of prevention. Okay, so other than haloperidol, is there any other medication? I don't remember. Is there any other specific management of delirium?
Dexmedetomidine is also used.
Dexmedetomidine, yes, for sedation.
Ketamine, basically haloperidol, benzodiazepine, ketamine, and dexmed. These four medications, but midazolam can cause the delirium, as you have already mentioned.
Yes, dexmedetomidine
Sir,
is.
haloperidol also caused QT prolongation. So if patient is prone to develop
Actually,
arrhythmia, we can also give.
this is theoretically, the haloperidol. We are using haloperidol for QT prolongation patient. Theoretically, it is right, but when you treat patient for delirium, you can use haloperidol in a low
Low
dose.
dose,
No
actually, it will be
problem.
single. And I will just add on to what he said. A number of things are theoretical, number one. Number two, actually, if you are only, the patient does not have any risk factor for QT interval prolongation, so isolated, it will not cause significant. But for example, now I tell you, if patient is taking quinolones, okay, and the patient already have some arrhythmias, okay, and now you are also giving haloperidol or any other medication which can prolong. Patient also received amiodarone. Okay, so now it can actually, it can precipitate. Okay, so you just have to, practically this is more important. Or you can say, if you are asking, if they are asking you in the exam, you can, you have to be diplomat. So you can tell that whenever we are using haloperidol, if there is some other risk factor for QT, you have to be careful in using it. That's why that answer will be a smart answer. Okay, so try to be diplomatic. Don't tell closed-ended sentences. This is actually closed-ended sentences create problem. Don't use it. Okay, unless they are asking you very specific pinpoint, try to be a little diplomat. That if this will happen, I will do like this. If this happen, I will do like that. So this is how. So there are some I will just discuss few more things. There are concept of various teams in ICU. I have actually discussed in detail. It's there in YouTube. Already I discussed. So some of the teams you should be knowing: rapid response team. This is also somehow related to ICU. Number one. Number two, critical care outreach team. Have you heard about it? Critical care outreach team. Have you heard about it? Anyone? Yes, please. Actually, the simple concept of outreach team is the patient who are step down. You can say that's sort of step down, and then patient is in the was ICU and now shifted to ward. So this is the concept of critical care outreach team. So there you are taking care of the patients who are just step down. There may be some more words you should be knowing, but you should be knowing about with reference to RRT. Actually, the concept which the Muse and Pews early warning scores and rapid response team, what is it? Because they can ask you about this thing. Okay, so you should be knowing about it. Tracheostomy team is like the patient who have tracheostomy. There is a protocol for tracheostomy care, and because there may be decannulation team like who are doing it. So these are somehow related to it. Similarly, there is another team which is actually coagulation team. And sorry, this is anticoagulation team. So actually, these are cardiologists, and they are managing the anticoagulants and something like that. How like they are managing the hospital. So just let me see. Just a second, please. Yes, another important topic you should be knowing with reference to ICU is ICU transfer. Actually, there is transfer from within one department or one service to other service. This is one transfer. And there may be from one hospital to other hospital via some ambulance or through air transfer. Okay. So you should have some concept about such thing. Another topic just touch my mind is actually an ICU patient coming to OR. Okay. So the same thing which we have already discussed, patient may be unstable, patient may have vasopressors, different lines are there. Okay, so you have to be very careful. Maybe there is a inotrope or vasopressor going and you flushed it, it can create problem. The patient was on TPN and you suddenly disconnect, patient can have severe hypoglycemia. Okay. Similarly, during transfer, CVP can dislodge, arterial line can dislodge, patient may have tracheostomy, patient might need another important point with reference to this thing. ICU patient coming for OR is that this patient might require high ventilator settings. Patient have high PEEP requirement or high FiO2 requirement. And during transfer, the ICU transport, actually either the patient is coming through umbo bag or patient is coming through ventilator. That ventilator will not be as good as ICU ventilator. Even the operation theater ventilator might not be as good as ICU ventilator. So this can create a problem. Okay. So they can ask you any question that they can create any scenario like that. The ICU patient is coming for OR. Another thing which is related to this thing will be sometime the patient is DNR, do not resuscitate. Okay, and that patient is coming to OR. At that time, they change the status. They change the status of DNR to resuscitation, and then once the patient is gone back, they change the status again. Okay, they are coming for like PEG tube or any procedure like that. There can be this procedure can be anyone. Like one of them will be patient on high dose vasopressors, developed mesenteric ischemia, gut ischemia, and now patient is coming for resection anastomosis. So this is one example I've given you. So there are a number of things. Patient on ventilator coming to, of course, there is a concept of now majority people they are doing bedside tracheostomy, but such patients can come for tracheostomy as well. So like you can track which procedures they will be these patients will be coming. So you should have a good concept about DNR. Actually, itself is a topic which they can ask you. So actually, if there is no hope or there is no like low, so then two consultants decide, they discuss with the family, and then they consider a patient as DNR, do not resuscitate. These are actually very small points which you should be knowing, but you should have a concept what is DNR. Similarly, with reference to another things, the like is brain death and organ donation. Okay, so I think mm, I will stop here, and
Tetanus
like
also very important, Dr. Zishan. One more
yes,
topic, tetanus.
yeah.
And
Actually, the tetanus also they ask in tetanus. Then there is a snake bite. There are so many topics
mhm.
about it. So I think we can have another session on ICU in coming days. Okay, I
Can
have this.
anybody comment on the role of levosimendan in intensive care unit? What is levosimendan? Anyone know about this drug, levosimendan?
I
Anyone
think
from part two?
some of them have already
Gone.
left.
Okay. Okay.
Okay, you tell Zulkanan, you tell about it. Even I
Actually,
don't remember.
levosimendan जो है वो is a calcium sensitizing inodilator. Okay. And it is used in the chronic heart failure. तो इसको आजकल जो है ना nowadays it is used in sepsis, renal failure, septic shock, cardiogenic shock.
Okay,
तो ये लास्ट वाइवे में एक से पूछा था, ठीक है ना, कि ये लिवोसिमेंटिन का क्या रोल है, ठीक है। तो इसका एक आर्टिकल है, मैं शेयर कर दूंगा ग्रुप पर।
please
तो
do
ये
share.
थोड़ा बाउंसर था थोड़ा ना।
Yes, one
And
thing that there are.
one more question they asked last time, one of my colleagues. Anyone know about is there any role of dexmedetomidine or neostigmine in PDPH patient? This is also they asked in last Viva. Anyone know about this, yani how the neostigmine or dexmedetomidine reduce PDPH? No one. Okay.
Speak
डॉक्टर
out.
दिशा नेक्स्ट क्लास जब आप करेंगे तो फिर बात करेंगे, अभी लोग भी नहीं है तो फिर इंशाल्लाह।
Okay. So thank you very much, all of you. Um, some of the topics I have already discussed before as well. You can find in the recording. So anyone can come out with any questions. You all are welcome. So thanks for your time. So see you again. Bye bye.
थैंक यू डॉक्टर दिशा।